Delivering care in the north is beyond challenging. It's approximately 1,600 kilometers from Kenora in the west to Temiskaming Shores on the eastern edge of northern Ontario, and that's the same distance as Kenora to Edmonton. And at the same time, we have a population less than the size of the city of Ottawa at 850,000 people. Residents of rural and northern Ontario have worse health outcomes than the rest of the province, a shorter life expectancy by 2.5 years, and poor access to healthcare compared to the rest of the province. And according to the Ontario Medical Association Physician Resources Integrated Model data, actual physician service utilization in Northern Ontario fell short of target physician services use by more than 600,000 services in 2021. That means people aren't getting the care they need by hundreds of thousands of visits. Northern Ontarians deserve better, and the OMA has outlined some immediate steps the government can take now to stop the crisis. So, without further ado, I'd like to introduce to you today's experts who are going to speak about the recommendations in more detail and share their real life insights and experience on the crisis that we face in the North. First, Dr. Jessica Kwapis is a general surgeon and chief of staff at the Sensenbrenner Hospital in Kapuskasing, Ontario. Next, we also have Dr. Sarah Giles, a rural generalist physician in Kenora. Dr. Giles is also an assistant professor of family medicine at the Northern Ontario School of Medicine University and a member of the Society of Rural Physicians of Canada. We're going to start with Dr. Kwapis, who will tell us about her experiences as a family doctor and explain why the OMA is urging action on the crisis in primary care. Over to you, Dr. Kwapis.
Thanks, Dominik. Want to imagine for a moment that you are a woman who is 37 or more weeks pregnant and you have to travel over 500 kilometers to reach a hospital that can deliver your baby. Imagine not being sure if you even want to have another baby after the stress of having to travel for your first. Imagine risking your life to travel to a location where your baby can be born, or worse, not being able to travel because the roads are closed due to snowstorms or other weather events. Imagine being the only hospital in an 800-kilometer stretch of highway in rural Northern Ontario that still delivers babies and the stress that that puts on providers in the system. Imagine also being a family physician who has been delivering babies for 24 years. The last 5 years, you've done it as the only obstetrics provider in your community 24/7. It's affected your health to the point where you actually have had to give up your practice, leaving the entire community without an obstetrics provider. Imagine the guilt, the self-doubt, the grief, knowing that your community needs help, but that you can't provide it anymore because it has just beaten you down. Does this sound extreme? It is, and it should sound extreme, but this is also real life in Northeastern Ontario. In June 2023, Dr. Richard Claveau resigned from family practice and obstetrics in Hearst, Ontario for health reasons. This left the community of Hearst with no option for delivering babies locally. To put that in perspective, Hearst is 6 hours from Thunder Bay by car and 3 hours from Timmins, which are the two hospitals on either side that have larger obstetric services. In Kapuskasing, where I live, which is an hour east of Hearst, our obstetrics program is still going, but barely at times. We have faced shortages of nurses, anesthetists, surgeons, and family physicians providing obstetric services, and we've been working hard to build and stabilize our program so that we could open our doors to the women of Hearst and their surrounding communities. We were almost there. We were looking forward to, by the end of this year, being able to say to these women in Hearst, come deliver your babies here, we've got you. But then one of our family physicians who had been doing obstetrics for 7 years also resigned, again, due to family reasons and the extreme challenge of being on call for obstetrics a lot of the time. So we're now down to 2 family doctors with obstetrical skills in this entire 800-kilometer stretch, and we risk losing them if we can't find a better way. to avoid the risk of not being able to reach a center with obstetrics care when they go into labor, women from Hearst and from other small communities across Northern Ontario are advised to relocate at around 37 weeks to a larger community. They leave their homes, they leave their families, their social supports, and they stay in hotels, Airbnbs, or if they're lucky and they have family and friends, they stay with them and they wait on average about 2 weeks in those communities to deliver their babies. This is expensive. The average cost for a relocation for delivery is around $45,000 to $5,000 per person per visit. And women across Northern Ontario are spending over $5 million per year to access delivery services. It's disruptive and it's totally inequitable. Imagine being in Southern Ontario and being told that you have to relocate to several hours away many weeks before your baby is born just so you can be somewhere safe. It would not be acceptable there, and it is certainly not acceptable here, but it happens all the time. There are those who can't relocate and they make the difficult decision to wait until they go into labor in the hopes that they'll make it there on time. Some make it to care, some don't. There have been deliveries in a taxi, in the bathroom of an emergency department that doesn't have obstetric services, in ambulances, just to name a few. Many women don't even receive prenatal care in their last few weeks of pregnancy because it's not being provided in their community because they're supposed to relocate. Thankfully, so far, there have not been any negative outcomes for women who have been far away from care when their babies were born. But it's only a matter of time before something tragic happens. This is foreseeable, and we have to do something about it before it happens. So what are we asking for? We have put in a proposal to the Ministry of Health for a different model of funding for family physicians providing obstetric services. This be essential for stabilizing supports and for making the field of obstetrics more attractive to people. The proposal is on the desk of the Ministry of Health. They have asked some initial questions, but we know that these processes can take years, and we do not have years for this to get sorted out. This has to happen immediately because the lives of our moms and babies depend on it. Kapuskasing is really working to become a hub of obstetrical care and surgical care for our part of rural Northeastern Ontario, and we do require additional resources to make that happen, including resources to pay visiting physicians to fill the gaps when we don't have the services provided ourselves. And I also just want to highlight finally a report by Dr. Ellie Orantia that was published through the Northern Policy Institute a couple of weeks ago. It's entitled Delivering Solutions, an Action Plan for Sustaining Rural Birthing in Northern Ontario. And he highlights many of the issues that I've spoken about today, along with 3 recommendations. One being investing more in education and training for physicians who want to go into obstetrics and being supportive of those goals. Another in that same topic of education is providing resources for physicians who are providing obstetric services in rural communities to go to larger communities for more high volume delivery experience on a regular basis or for upskilling. And this is actually a message that's being communicated as well by the Society of Rural Physicians of Canada for all rural physicians who require support for their continuing medical education initiatives. There needs to be additional investment in health human resources for Northern Ontario. And finally, there needs to be a systemic, system-wide approach and putting heads together to solve this problem, to come up with a strategic plan that will address these issues once and for all. And so investment needs to be made to pull the people together and the oversight to make that happen. My final point would be that Ontarians, we have discovered recently through a poll, over 90% of them believe that equitable access to healthcare ought to be one of the priorities for our province. This is not happening right now in Northern Ontario, and we can't just take healthcare resources from Southern Ontario to fund the crisis in Northern Ontario, because Southern Ontario also has many access challenges. Northern Ontario requires specific additional investment in healthcare and specific leadership to oversee what is happening by people who know the North, understand the North, and can help oversee the problems. Thank you very much.
Thank you, Dr. Kwapis. Now I'll hand it over to Dr. Giles. Dr. Giles, over to you.
Good morning. Thank you, Dominik. Thank you all for joining us this morning to talk about the crisis that is Northern Ontario healthcare. My name is Sarah Giles. I am a family physician, ER doctor, hospitalist, rural generalist. First, I'd like to tell you about what it means to be a rural generalist family physician, because that's really the model that Northern Ontario is based on. And if you don't understand it, it's a little difficult to understand what the crisis is. In Northern Ontario and much of rural and remote Canada, family physicians who are rural generalists provide care. What does that mean? These are specialist family physicians who have trained in a generalist model. That means that the person who provides primary care is also often the person who provides emergency room care, looks after inpatients, delivers your babies, perhaps does stress tests, does chemotherapy, runs the fracture clinic, does OR assists. So when we say we are short rural generalists, family physicians in Northern Ontario, what we mean is that healthcare as a whole is in jeopardy. Hospital care is in jeopardy. It's not just primary care that's the problem, it's the whole model. So if you can't, go to the hospital to deliver your babies, if you can't go to the ER because it's closed, the same people who staff that are staffing primary care, which means the whole system is falling apart. We need a model that supports rural generalist family physicians and our generalist colleagues, such as general surgeons, general internal medicine specialists, pediatricians, etc. We need a health human resource plan. Currently, there is no plan. The doctors that are saying there's a crisis don't seem to be getting through to governments who have the ability to look forward and say, we need this many doctors, we should be funding this many seats in medical school and this many spots in residency. Right now, that plan does not exist. And the current plan is sort of like, let's throw a bit of money and some open spots in medical school and hope it all comes out in the wash. It is not working. Where I work currently, we are exceptionally short of physicians in the ER. When I look at the schedule for the holidays, I have palpitations because I see my name on it. I see a couple of my colleagues and I see a lot of blank spaces. And it's not fair that the entire problems created by a system that doesn't have enough people or enough money comes down onto the shoulders of 11 people in my community. We just can't do it anymore. We are exhausted. When we talk about staffing rural and remote communities in Northern Ontario, there's an element that we need to understand, and that's many of these people are Indigenous, and many of these communities are Indigenous First Nations. The calls to action from the Truth and Reconciliation Commission, specifically numbers 18 to 24, talk about health. We know that there's a demonstrated decrease in life expectancy if you live in Northern Ontario. That gap in life expectancy enlarges if you happen to be Indigenous or First Nations living in this area. That is not acceptable. We need to give Northern Ontarians, First Nations people, everyone living in Northern Ontario, equitable health care. What does that mean? It means that it's unacceptable for the children of Northern Ontario to have to go to London, Ontario. Yep, that's right. So from Kenora to London, Ontario to reach the closest pediatric center that has ICU beds. Imagine you're a parent and your child is critically ill and you have to fly around the province to get to be with them, or maybe to get home at the end of it with a sick kid when you're exhausted. It's just not right. Now, some of you may be saying, listen, I live in urban Ontario. Why does this matter to me? It matters to you, A, because maybe you have a sense of justice and equity and fairness, but it also matters because if there are problems in urban Canada in healthcare, then rural Canada is on fire. And if we can't deal with patients close to home, that means we're sending them to urban centers. And the more beds we take up there, the fewer beds are available for people who live in urban centers. Furthermore, the cost to the system for moving patients is huge. They deal with this in safety issues and access issues, as Dr. Kwapis mentioned, but also in terms of the emotional burden of being so far away from your support system that you choose to forego care. I regularly see patients who are scheduled to have radiation into Thunder Bay decline to go because they don't want to be a 5.5 hour drive from their families. They would simply rather deal with the consequences than have to be outside of their communities for a long period of time. We need to care about rural Ontario as well, because we are more and more often training our physicians in rural Ontario. When we create increasing spots in medical schools, we can't accommodate all of those people in urban places, so we need to move them to rural. And that's great, but they have to have good experiences. And if they're coming here and not having good experiences, then they're not going to want to do it. And if we can't accommodate them, then we cannot continue to enlarge the enrollment of medical schools. This affects urban people. How can we make the problem better? Well, we can look at a paid mentorship program. The Ontario College of Family Physicians used to do this. There are various groups that could do this, where we support those working in rural environments with paid mentorship with people who have worked in similar environments, who have the expertise to help them out. At any transition in life, work in rural communities becomes scary. You've been out of the community having a baby, or you've been out of practice for a year and you want to get back into the emergency room. We need to support these transitions with people who understand and have the expertise to help these doctors feel confident and sure that they're giving the best care possible. This can be done. Finally, we hear a lot about the economic engine that is Northern Ontario driving the economy. We cannot have mines, mills, farms going if we do not have a robust healthcare system. Nobody wants to move to a place where they cannot access care. It is not fair to say to Northern Ontarians, you're rural, you don't really need that same access. Yes, they do. Rural generalists, family physicians, who are the Swiss Army knives of medicine, are exceptionally well-trained and a great deal for the healthcare system. We need to make sure that these generalists are supported, are paid well, and are treasured by the communities. This can be done. We just need some change. Thank you.
Thank you, Dr. Giles. Before I turn it over to our media colleagues for questions, I'd like to say a few words about our Stop the Crisis campaign and our recommendations to government for solving the crisis urgently and immediately in Northern Ontario. Even though rural and Northern Ontario has a particular and unique set of needs, all the things our Stop the Crisis campaign are advocating for apply and are often exacerbated in the North. And I think about, the need for family doctors, the importance of keeping emergency rooms open as that foundation, access point and safety net for the healthcare system, the need for better surgical and diagnostic services access and drop in wait lists, or the need for a specific workforce strategy. So there are three solutions that we have in our Stop the Crisis campaign specific to Northern and rural communities. Number one, we need a Northern and rural physician workforce strategy to help coordinate the ways in which we train, recruit, and retain physicians for Northern Ontario. We have a few of these disconnected elements, but these have not been aligned so far in a coherent approach. And we recommend the government work with us, with the Ontario Medical Association, to develop and implement without delay a Northern physician workforce strategy, including the creation of a coordination center that would work with doctors and communities and support initiatives that sustain, retain, and help recruit the workforce that we need for today and for the decades to come. This would be similar to something we already know in Canada, which is the Rural Coordinating Center in British Columbia. And we have to pay special attention to those high need specialties in Northern Ontario where we know we have significant gaps: family practice, psychiatry, pediatrics, obstetrics, maternity care, anesthesiology, internal medicine, and the list goes on. And on top of that, we need that as medical schools expand across the province, including at Northern Ontario School of Medicine University in Northern Ontario, there's an urgent need to keep our doctors, who are also teachers, and building up the workforce of the future in communities where we want our graduates to practice. A workforce strategy would include the needs of the clinician teacher. Number two, we need to make sure that services in hospitals can stay open and available, and they should be straightforward for doctors to cover for each other. And because of that, we need a regional credentialing system to make it easy as possible for doctors to support each other, to support delivery across different communities in northern and rural Ontario. And that kind of system would drop the barriers to getting privileges at different sites and make it easy and straightforward for doctors to work together to cover regions across the north. And number three, we need doctors working in Ontario, and we need government to understand that there's a broad skill set, that Swiss Army knife approach of rural generalism that we have in the North, and that the needs of the North are special and particular, and they're different from other parts of the province. So we need programs that specifically support doctors in the North to develop new skills, to maintain the skills that they have, and to provide care for their communities, because that kind of care is going to be different than the care that we do, that I do as a doctor in a city. So now I'm going to open it up to our Q&A session. Please put your questions in our chat in the Q&A window, and I'll hand it over to the Ontario Medical Association team member working with us today, Dr. Jordan Kerbel, will moderate this portion of today's briefing.
Thank you, Dr. Nowak. Hi, everyone. I just want to take this opportunity to say thank you again for attending today's briefing and to remind you to simply put your questions in the Q&A chat function. Please do include your name and your media outlet if possible, and we will do our best to get to every question. Again, please put your questions in the Q&A chat, include your name and the name of your media outlet. We will get to as many questions as possible. Okay, the first question we're going to go to is from Len Gillis with Sudbury.com. Len's question: how helpful would it be for Ontario to offer some sort of significant financial incentive or big tax breaks to entice physicians and nurses to set up practice in the North and to stay in the North for 5 or 10 years? And how soon could something like that happen? For this one, we'll throw it over to Dr. Giles. Dr. Giles, please.
Hi, Len, thanks for your question. There are some financial bonuses for people who choose to live and work in the North. But believe it or not, they're actually really hard to qualify for. We have a number of physicians in Kenora who don't quite meet the full-time threshold as deemed by the provincial government, and as such are not eligible for any of these bonuses. And while it is helpful to encourage people to set up practice in the first place, and we absolutely need to be doing that, and could that be started tomorrow if we really wanted to? Absolutely. We know that retention is probably an even bigger issue. We need to keep the experienced local physicians where they are and work really hard to keep them happy, because you can't recruit new people to come into an empty system. It just doesn't work. We need to have the sort of anchors in a community who are there to teach the students, who will have a great experience so that they'll come back as residents and then decide to stay as staff. We need to have the people who can mentor new physicians. And how do we keep people there? It's not just through return of service agreements, which is if you stay here for 4 years, you get X amount of money, because really the studies show that doesn't work very well. It's helping the people who are in the communities have a reasonable work-life balance and not feel like the weight of the world is sitting on them. Part of that is through bringing people to the communities, through education leave, through having locums, but it's also community coming together to help make everybody's lives better, and including physicians in what's going on in the community, and maybe helping to lighten their personal load when it comes to working, sometimes really crazy hours. We also know there are physicians out there who can't come to certain communities, and they want to, but there's no childcare. So we really need a coordinated effort from small communities to help get rural physicians and healthcare providers there and keep them there.
Thank you, Dr. Giles. The next question is going to be for Dr. Kwapis. This is from Rajpreet Sahota of CBC. Dr. Kwapis, Kapuskasing's The Sensenbrenner Hospital announced that its obstetrics program is at immediate risk of closing a month ago. Is there any update on where this stands now?
Yes, thanks for the question. So our situation has not really changed since a month ago, and I should clarify that we are not currently in a situation where we're looking at permanent closure, but with two obstetrics providers only, they cannot cover the entire 365 days of the year. And so we are relying on visiting locum physicians to fill some of those gaps. We do have physicians who are willing to come and provide those services. We do not have a way to pay them. So currently the hospital has been paying out of its operating budget, which according to the Public Hospitals Act, it is not supposed to do, but is doing so just because it's committed to keeping our services open. Having said that, our hospital, as with probably every hospital in Ontario, is in a very difficult financial situation, and we can't keep paying out of the operating budget for our locums for very much longer. I can't give you an exact time frame on that, but at any time, really, something could change. And if we don't stabilize, first of all, the funding model so that we can actually get locums and have physicians that are able to provide coverage, there is really an immediate risk of having to close for a 24-hour period, a 48-hour period, a long weekend, even a week at a time. And that would leave that entire 800-kilometer stretch with no coverage. So we're hanging on, and we're really just pleading with the government to hear that we need this funding immediately so that we can stay open. Thanks.
Thank you, Dr. Kwapis. The next question is from Lydia Chubak, CTV News, Northern Ontario. Her question is, how are municipalities helping you resolve this issue that obviously has been ongoing for a long time? And what is it looking like for the holiday season? How should people plan and prepare? I'll throw this one over to Dr. Giles.
Thanks. Municipalities are key partners in healthcare provision, and unfortunately, richer municipalities have deeper pockets and can provide different things when recruiting physicians. We have some communities who are offering up to $100,000 signing bonus. And, that might work for that one community, but the community who's another hour down the highway who can't do that suddenly is behind the 8 ball. And there is a bit of a arms race to who can offer the biggest signing bonus. And I think, that really puts small communities that are poorer at an even greater disadvantage. And I'm not sure how we fix that, but when you look at it through an equity lens, it's a little bit scary. What can people do to help prepare for the holiday season? Definitely plan ahead. That means get the refills of the prescriptions you need so that when it comes to holidays, you're not being forced to go to the ER to get those. Deal sensibly with small problems before they get large. That might mean a trip to the emergency room or a walk-in clinic for something that seems a bit small, but you might want to nip it in the bud rather than have something become big. We know that Boxing Day can be an especially deadly day for people because maybe they should have gone into the ER when they had the crushing chest pain. So I think it's, looking around, asking your families, saying, am I doing the right thing? Do I need to get this looked at? And also, I'd say wear the gear. If you're going to be, sledding, downhill skiing, doing activities outdoors that we all enjoy and love, it's really important that you wear the safety gear and take part in these activities in a sober manner.
Thank you for that, Dr. Giles. Next question is going to be for Dr. Kwapis. Dr. Kwapis, this is kind of a three-part question. Will there be sufficient staffing in obstetrics to manage the influx of pregnant patients? How will this be handled? And what if there are complications during childbirth that require additional support?
These are excellent questions, and we share a lot of these same concerns. Obstetrics in a rural community requires a major team effort. So we need, in larger centers, you have OBGYNs who are specialists who do both, who can do the deliveries, can do the cesarean sections, and also manage the complications. And typically there would be a pediatrics team that would care for any issues with the babies. So it's a little bit different in rural communities. We require the GPs, the family physicians, for the most part, do the deliveries, but very few family physicians do cesarean sections. There's the odd exception to that, but in Kapuskasing, for example, none of the GPs do cesarean sections. So it's the general surgeons who have that skill and do that. So we need a stable general surgical service. We need anesthesia, which again is provided by general practitioners who have extra training in anesthesia. So we need a stable workforce on the anesthesia side, and we need the GPs who can do obstetric services. We also need nursing, and we don't just need nursing on the obstetric side, but we need it on the operating room side. So there's a really huge human resource requirement. And the family physicians, for example, if we were to have an obstetrics gynecology specialist come and locum here, they don't actually have in their scope of practice the ability to take care of a baby who is very sick when born. And so that's another job that falls on our family physician colleagues with the obstetrics specialty. They also care for newborns, and so it, as I say, it's a team effort and really requires stability on all those sides. And I would say in rural communities, including Kapuskasing, so many of those services and positions are in jeopardy and are very vulnerable to losing whatever place of stability they had. So it is a concern, and it just highlights again the need for a specific human resources plan for Northern Ontario. What are the consequences if a sick baby is born in a small community like this? Well, I can tell you, for example, that recently in Kapuskasing, and it's not the first time this has happened, a baby was born who required advanced life support, who was ultimately transferred to Ottawa for care. But it took 8 hours for the neonatal ICU team to get to Kapuskasing to transfer the baby to Ottawa. So during that entire 8-hour period, staff were taking turns bagging. So they have a mask over the baby's mouth, and they are pushing the bag to help that baby breathe for 8 hours straight. Without a team that can do that, that baby would have died in our care. We also need teams to have that expertise. There needs to be enough training for them and ongoing training. There also needs to be access to specialists. That doesn't require 25 different phone calls to find somebody in a higher center who can help you out when you're in a pinch. So there are such services for adult intensive care situations. They're working on one for pediatrics. There's a little bit of a trauma option. There is some virtual support for ER physicians, but there needs to be similar virtual support and a one phone call access to get a specialist who can help with an obstetrics crisis or to help with a very sick baby. So yeah, it's scary, and this is really why we're sounding the alarm and hoping that this message gets heard loud and clear, that that this is a crisis and lives really are at risk if we don't stabilize the situation.
Thank you, Dr. Kwapis. Dr. Nowak, you wanted to add something to that response.
Yeah, you know what? I want to build on the question around municipalities as partners. We have seen that across the province, but the reality is, in the absence of a plan from the province, in this leadership vacuum that we have right now from the province, and in a plan for Northern Ontario, a plan for the workforce in healthcare, we're seeing this Hunger Games come up, a Hunger Games where communities are competing for doctors against one another. And it comes down to, who can offer what and how communities do it themselves. And what we really need is a plan that's thoughtful, that's thorough, that builds capacity, not just for this week or next month or next year, but for years to come. And that has to come from the province. It can't come community by community, which is what the situation is right now. And it's leading to this Hunger Games at the expense of patient care.
Thank you for that, Dr. Nowak. We do have a question from Carol Martin with Elliott Lake today. Carol asks that we've mentioned stats about mortality and other statistics. Is there a place we can access the data that you referenced? Um, Carol, I can tell you that from the Ontario Medical Association, we do have a lot of data in our Stop the Crisis, so it's stopthehealthcrisis.ca. We can also send you the link if you were to go to that link. There's lots of data and analytics vis-a-vis northern communities. But I will ask Dr. Kwapis and Dr. Giles, is there anywhere else to reference the data that you've been speaking about earlier?
The Canadian census does break things down by province. There's not great information on region by region, but that is a place where we can see the decreased life expectancy of people who live in Northern Ontario when compared to their urban colleagues.
And I had mentioned earlier the report that was published through the Northern Policy Institute a couple of weeks ago called Delivering Solutions and Action Plan for Sustaining Rural Birthing in Northern Ontario by Dr. Ellie Arantia. That also contains a number of statistics. And also that not all of our data in Ontario is very robust yet. That's another need that we have. So some of the data has been extrapolated from rural British Columbia, where they have a more robust data collection and analysis system. But the statistics that I mentioned and more, many can be found in that report.
Okay, thank you. Follow-up question from Lydia Chubak. Lydia says, thank you for taking her initial question. Have any meetings with the province taken place recently, or are there any scheduled in the coming weeks to address your concerns? Dr. Kwapis, you did reference reach out to government, so I'll throw that to you first.
Yes, that's correct. I have had some initial communication initially by email from the Ministry of Health contracts unit regarding our proposal and asking for some additional information. So that additional information was provided, and I do have a call set up next week with this branch of the Ministry of Health to discuss this further. So hopefully that means that they are taking this seriously, and we just hope that it continues to stay on the top of the pile and gets expedited through.
In Kenora, we've recently had a proposal accepted by the Ministry of Health to look at a new way of funding care in town, which will hopefully be good. But the problem is these new deals, etc., do not come up until we have passed the point of crisis. When you destabilize an entire community of healthcare providers, it is impossible to recruit into that, and it's really hard to retain. I would hope that the Ministry of Health can look forward and say, we need to stabilize the workforce before it is decimated, and that the ministry will be proactive in offering solutions to other communities before they reach the point of catastrophe.
And over to Dr. Nowak. Dr. Nowak, please.
Yeah, we just had our Queen's Park Day a few weeks ago with almost 200 doctors from all across the province, including from northern and rural communities. And we hand delivered the Stop the Crisis priorities to elected officials across party lines, including to the Minister of Health, the Premier, other elected officials that are, at the tables making these calls around our healthcare system right now. So government is aware of our priorities, and these are urgent priorities because they're the parts of our healthcare system that are beyond crisis, they're in catastrophe. And there's a reason that saving healthcare in northern and rural communities is on near the top of our list among, finding everyone a family doctor, among keeping emergency departments open. All of these things are connected, right? So government is aware of our plan. It's now up to them to enact these changes that would get people the care that they need. And again, we're talking about the foundational points of the healthcare system that everyone should deserve. Everyone deserves across the province, including in the north.
Thank you, Dr. Novak. We have another follow-up question from Rajpreet Sahota with the CBC. The question is for Dr. Kwapis, mentioned a different funding model that has been proposed to the Ministry of Health. What would that funding model look like exactly, Dr. Kwapis?
So most of physician remuneration is based on what's called a fee-for-service model throughout Ontario. And what that means is you get paid per episode of care for what you do. You can imagine in a rural community where maybe like Kapuskasing, for example, we have 80 to 100 deliveries per year. So in a week, maybe there would be one or two. That means that you are making yourself available for a lot of time where you might not actually get called in, and you're essentially volunteering that time. So what the funding model addresses is to shift from a fee for service model to more of a different model that provides a more stable remuneration model for your availability and expertise. These are called alternate payment plans, and they have been brought in for many different specialties across the province and have been quite effective in helping to sustain rural services. So that's the type of model that we're looking at for GP obstetrics as well.
Thank you, Dr. Kwapis. We have time for one last question. I'm going to throw this one over to Dr. Giles. Dr. Giles, we're seeing many physicians in northern and rural areas closing their practices or retiring. Why is this happening so rapidly, and where will their patients go for care?
Yeah, so the question of, why are rural and northern doctors closing their practices or retiring, and where are people going to go, is one that keeps me up at night. I think we have reached a tipping point where doctors who work in rural and remote communities are saying, you know what, I just can't do it anymore. I am exhausted. When the doctor who looks after you in clinic is the same one who works in the ER, is the same one who does the surgical assist, is the same one who looks after inpatients, there's only so much you can do. And I feel like the healthcare professions did a lot during the pandemic. They put their lives on the line. They worked a lot of hours. And in short, my personal opinion is that people ran out of goodwill. There's only so much you can do for so long before you say it's not worth it. You can throw money at the problem. You can add bonuses for every ER shift you pick up. But if your life is falling apart because your family never sees you and your kids are wondering where you are, if you are, every day I see the ER schedule that has huge gaps in it, and I think, okay, what mental gymnastics can I do so that I can get myself in there? When that becomes an everyday problem, it is exhausting. And there's a point at which the money is not worth it. You want to give your best, but you don't feel like you're giving your best. And you feel like you can't get patients what they need, and you give up. What's going to happen with the patients? That is a great question. There's a huge number of unattached patients in Kenora. We do not have a walk-in clinic. The closest walk-in clinic is in Winnipeg. The answer then becomes go to the ER. Well, we can't staff our ER, and we are facing closures every week. And then the volume just goes up and up and up. And then the acuity of problems goes up because people don't want to come in because the wait is so long. And then we get backlogged because we have people who are critically ill. Where are patients going to go? The answer is going to be to the ER. And that's just going to make all of the problems worse. What is the solution? I don't know. There has to be a huge influx of doctors, nurses, nurse practitioners, everything. And until we have a rural health and human resources plan, we're just flying blind and sticking our heads in the sand. So the time to act is now, and it has to be in a coordinated manner, and it needs to come right from the top.
Thank you, Dr. Giles. Okay, we're going to throw now just to some closing remarks from all of our panelists. Dr. Kwapis, if you don't mind, I'll begin with you.
Thanks very much. And I would really echo what Dr. Giles was just saying as well about the need for a concerted effort and plan for this. 20 years ago, there were 20 out of 35 rural hospitals in Northern Ontario that were providing obstetric services. We are now down to 9. Others are going to close if this doesn't change. And there's issues not just in obstetrics, but across all different rural generalist specialties, as you've heard so far. We need specific funding and investment to solve this problem in Northern Ontario. We need specific leadership from people who understand the North and its challenges to come together and to create a specific plan for health human resources, as well as models of care that will solve this issue. And I would just emphasize again, it needs to be specific to the North. I would invite government from Southern Ontario to come up and drive these long stretches of highway and get a sense of how isolated it actually is, and imagine what it would be like to live in these small communities. It is just not the same, and there's no substitute for the experience and knowledge of what's going on up here.
Thank you, Dr. Kwapis. Dr. Giles.
Thanks. What needs to be done? I think collectively, as voters of Ontario, we need to pull our heads out of the sand and understand that we are facing a crisis today that will be a catastrophe tomorrow. We need to vote for people who are able and willing to come up with a strong plan that will support healthcare providers today, tomorrow, and in the future. That means funding, that means mentorship, that means educational opportunities. If we fail to do that, the healthcare system that we knew and love of 10 years ago simply will not be there to support us in our time of crisis. It is not good enough to say people live in a rural place, they chose it, it's okay. That is urban-centric and has a large degree of racism to it when we consider the First Nations people who live in Northern Ontario. We need to look at the problem with compassion and understand that there needs to be like a generational shift in how we fund healthcare if we want it to continue as it does. We've talked a lot about this sort of doom and gloom. I do want to say that I grew up in Toronto, but I hide it well. And I really love living and working in a rural community, and I care about my neighbors and my patients, and I want them to have the same life expectancy as people who live down the highway. I invite any elected official to drive from Toronto to Kenora in the winter. As you do that, stop into the ERs along the way and see what we're doing to keep things going, and appreciate that the healthcare providers that are currently working in rural and remote communities, as well as our urban colleagues, are ruining our lives to give people the life-saving care that they need. And we can only do this for so long before we give up and retire.
Thank you, Dr. Giles. Dr. Nowak, last words, please.
Yeah, thank you, Jordan. You've heard it from all of our panelists. We have a crisis in healthcare and a crisis turning into a catastrophe in many northern communities. Everyone deserves access to a healthcare system that works for them, where they can reach out to it and that they can get what they need from it. And we have 6 stop the crisis priorities that also apply to the North. Number 1, everyone deserves a family doctor. Number 2, we need to preserve care in Northern and rural Ontario, because we deserve it too. Those of us who live in the North deserve the foundation of care as well. Number 3, let's keep emergency departments open. Number 4, let's cut back on wait lists for specialists and diagnostics. Number 5, let's have a workforce strategy across the province, and the province needs to lead this. And number 6, let's bring in innovation and technology so that doctors can focus on patient care, not navigating the paperwork, the sheer bureaucracy of the healthcare system. You can see those priorities, details, the stats, and more at stopthehealthcrisis.ca, stopthehealthcrisis.ca. That's available to you. And if you didn't get to ask your question, or if you want a more detailed conversation with any of us, contact us at media@oma.org, media@oma.org, with any requests for interviews or information. We're very happy to help. We'll have a recording of this session available later this afternoon. I do want to thank everybody for joining us here today and the work that you're doing in moving our healthcare system to a place where we can be proud of it again in the coming years ahead.